part of the study, you will be confused a little bit because Dr. Waid, he get through all of these elements. He would like to study the uncorrected distant vision, corrected distant visual acuity, corneal astigmatism, K reading, central cornea thickness, auto-refraction, subjective refraction, and patient satisfaction. He would like to compare the two groups, Group A and Group B. And he would like to see which one have the priority or the advantage over the second group. And he used the statistical analysis t-test bare two-tailed p-value to follow up the patients for 3 to 6 months to see the final outcome for each element. And he starts with a valid questionnaire for the patient to see the satisfaction of each patient before and after the surgery. As you can see here, there is a detailed question for every patient. Why he motivated for surgery, what is his goal, and he ranked it from 1 to 5. If he's not important or if he important, if he's satisfied or not satisfied. Then functional visual assessment, and lastly, if he experienced any symptoms or complications after the surgery, and he graded. And then we ask if he's satisfied or not. Let's see the results. You see through this graph, the upper line represents the Mayo ring, and the bottom one is going for the K ring. Both groups improving by the logMAR by the first month of the after the surgery, and continue improving for the 3rd month, and he gets stability around at 6 months. While as you can observe that the K ring a little bit, they have advantage in the visual acuity even for the uncorrected vision. While in our statistics, we found a significant improvement in uncorrected vision for both groups, but no difference. While in the corrected, you can also observe that both groups, they improve, and more with K ring. But our statistics shows that there is significant improvement in corrected vision, but in a group A, the K ring, they have statistically significant at 6 months. So final visual acuity, it shows to be better with the K ring. We compare also the K readings, almost the same. There is no much difference. And we conclude that there is significant flattening in K readings over both groups. The main reduction in the Group A, the K ring, you can see that it reduced the Ks by 4.5 almost. And the Mayo ring, it reduced the Ks by 6.5 diopter. But there is no statistical difference between both groups. Auto-refraction, almost the same. There is no difference between both groups, with a significant reduction in both groups. Central cornea thickness, both groups start with a certain thickness and almost they end with the same. So they don't lose anything in the central cornea thickness. Remain unchanged in both groups. Corneal astigmatism, the graph usually, this graph funny a little bit. As you can see, they cross each other. So sometimes there is a fluctuation among the last 6 months. Sometimes the K ring give better, sometimes the Mayo ring better, but finally there is no difference. Result, the uncorrected distant vision improvement was statistically significant in both groups, but the corrected distant vision finally at 6 months, it shows improvement in the K ring only. K readings, significant improvement in the 1st month, and there is no difference between both groups. Central cornea thickness remains unchanged. Subjective refraction and auto-refraction, there was no difference observed. In this topography, we can see the Mayo ring. You can notice the noisy maps in the left side, and how the maps change after insertion of the Mayo ring. As you can see, the shadow of Mayo ring here, and how's the astigmatism, how's the cone, it displaced totally inside the ring. This is another topography. This is the Kera ring, patients before and after. And we'll talk now about patient satisfaction. The surprise here that the patient satisfaction is not related to vision. As I mentioned before, that we found that the final corrected vision was better in Kera ring, but the satisfaction, it shows another result. In patient satisfaction, almost all patients tracked desired of improved and aided vision, almost 89%. Relief from glasses, 77%. But in group A, satisfaction becomes 77% only, while in group B, the Mayo ring is 89, with overall satisfaction 83. Patient usually satisfied. And here we compare how is the arc, the Kera ring with the circular Mayo ring improve all of the parameters. Uncorrected vision, corrected visions, K reading, and satisfaction. Complications, in the group A, we had 2 cases. One of them get infiltrative keratitis in the segment. And the second one, there is migration of the segment, which was removed in the first week to avoid melting. In the Mayo ring group, we combined one patient with CXL because he progressed with the keratoconus even with the Mayo ring. Conclusion. Both procedure, either one segment or 2 segments, circular or 2 segments, the Kera ring and Mayo ring are effective and safe in improving uncorrected vision and decreasing myopia and keratoconus. Reduction of myopia and uncorrected vision were noticed at 3 months visit for all subjects, and further slight reduction was found at 6 months in the group A. Corneal curvature flattening significantly over time and reach after 3 months. The 2 procedures show significant effect in reducing Kera ring. And further reduction in Kera ring also we found it. In conclusion, here, despite the fact that the patient treated with Kera ring implants had slightly better visual acuity at final visit than those treated with Mayo ring, the Mayo ring lead to great reduction in coma operation and better patient satisfaction. Thank you.
So this is تطلع من هنا. هذه
الفيديو؟
لا مو الفيديو، برزنتيشن هذه بس. Yes. Before we move into discussion, and I asked really the audiovisual people to make our discussion face-to-face rather than text. So we will have microphones. If you want to ask questions, you can raise them directly and we can entertain them directly. That's even better. I want really to touch with you briefly, just to save time for the discussion. How could we enhance our ICR results by a light BRK? So this is a 2-step approach to manage keratoconus. The first step is really to do ICR, and the second step is to improve it with light BRK. And I published this results in 2013 in the Journal of Cataract, and the idea really to select a patient, the right patient for ICR, observe them for 6 to 12 months, enhance them with a BRK and CXL, and review the results of this approach with you. We already discussed this, and I'm sure during discussion, it's a gradual loss of visual function happen over years from somebody with excellent spectacle vision move to a good, still good spectacle vision, then a bad spectacle vision, then those wrinkles which say that this is an impending corneal scarring, then a corneal scarring, and eventually a terminal keratoconus. So I'm not going to we already discussed this in the video that that's the way we discuss our patients, and how we group them and select them and choose the right procedure for them. If somebody still have a good spectacle vision, we manage them with ICL or BRK. But if the patient has a bad spectacle vision, we do 1 or 2 step according to the level of the disease and the severity, ICR alone, or we combine it with a BRK CXL. And for impending corneal scarring, we don't have in hand except graft surgery till now. We don't know what will happen in the near future. And these are the results of 12 patients. 12 patients, 6 right, 6 left, 11 virgin eyes and 1 post-LASIK ectasia. Their mean age is 30, but ranging from 16 to 43, 11 male and 1 female patient. And I'm not going to present all the cases, but I want to show you what happened after the significant improvement in all the 12 cases after going into those 2 steps. What happened to spherical equivalent, what happened to max K, what happened to uncorrected, what happened to uncorrected, and look even at the topography. The huge distortion on the left side, pre-IC, and the upper column, pre-ICR, and the final column after doing those 2 steps. Like for example, this case, and if you look at the bottom, the patient is almost have a close to normal anterior surface corneal topography after doing those 2 steps. This is another case. This is number 2. The same thing, and I will summarize to you at the end, but I wanted really to show you what happened with different level of success. See, look here very successful, here a little reasonable, here we still have a good success, but we still have some irregularities in the center of the cornea. And those 12 cases I'm showing you, I will summarize you what happened on a table which show you the results of in sphere. We were able to improve the myopic correction on those cases. Look, from -3 to -9. The average correction was -3.8 with additional 1.3. And our mean sphere is becoming 0.06. Stigmatic correction, also we had a better stigmatic correction by managing those 2 steps. Look at the mean was -3.3, and the mean after ICR became -1.8, and the mean was less than 1 diopter after those 2 steps. The same for spherical equivalent. Spherical equivalent improved from -5.3 to almost half a diopter after doing those 2 steps. Corneal astigmatism, which is different than manifest. We measured the corneal astigmatism, and we were able to save at least 2 diopters by those 2 steps, from 3.9 to 2.06. Uncorrected visual acuity. Also, there are a number of lines, 4 lines in the first step, and an additional 2 lines in the second step. Best corrected visual acuity, again, was better. And look at the narrow range of best corrected visual acuity, where people almost within the normal range, but after those 2 steps, compared to the wide range at the entry of the study. Max K, there is a significant improvement in the max K and in the average K of those cases. Coma. we were able to conquer almost 1 micron of coma. 1 micron, from 2.5 to 1.5, which is really a very good achievement to achieve in those highly aberrated eyes. So this is a table which summarizes what we have achieved. 3.8 lines, another 2.3 lines, 6.1 lines in the uncorrected visual acuity, another almost 1 line in the BIS corrected, another 1 more line in the BIS corrected after the second step. So we gained also two lines in the BIS corrected visual acuity, a spherical equivalent, 3 diopters, additional 1.8. So we almost were able to conquer around 5 diopters of spherical equivalent. Corneal astigmatism, we were able to correct at least about 2 diopters of corneal astigmatism. We're able to flatten the cornea by 6 diopters. In the max K and in the average K was almost 5.8 and 1 micron of coma. So based on our review, ICR followed by BRK-CXL is an effective and safe approach in making a functional change and improving the lifestyle of the cases of keratoconus. We recommended to do this. These are our recommendation for selecting the cases. And I would like to thank you for listening to this presentation. I think it's time to start discussion, and since we still have about 15 minutes, if somebody have any questions, we can entertain them. While we are collecting questions, I want to ask the panel, when you consider CXL, is it before, simultaneous, after CXL? What do you feel about it? Yes, good. So you do them before ring first. How about you, Bassam? So, Raed, you want to add something? Yes. I mean, presence of CXL before doesn't preclude of doing ICR. You can achieve good results by doing ICR in a cross-linked cornea. It's true that we prefer to start on a virgin eye to do the ICR, and then you move on by your CXL. But if you are faced with a case which already cross-linked, you can proceed doing the ICR, and sometimes you get some good results. There are some precautions in the laser setting. You need to increase the energy a little bit in order to have a better channel dissection, but otherwise it's almost the same standard protocol done with the standard ICR. Second question for the panelist is how you select your rings. I mean, do you rigid with nomogram, or you do a personal adjustment? What do you feel about it?
never do the advanced cases, because many of these advanced cases will defer to grafting at the end. So we have very high selective criteria to choose doing these cases. And if you stick to very high selective criteria, you will end up with successful cases. And about the nomogram, at the beginning, I mean 2008 and 7, I go with the schedule mentioned by Dr. Bassam, but after a while, it depends on the cone and the placement of the cone, and I depend on my personal experience to place the ring where you need to displace the apex of the cone to the center of the pupil, as well as the incision site, because some of the cases you might mislead about with the nomogram. This is my personal experience.
Bassam?
Yes, this is a very good question, Dr. Walid. My strategy for that, first of all, I have to look to the patient, because realistic expectation is very important. It's very, very important. I have to tell my patient what will expect based on his data. For my nomogram, I do it with the manufacturer, double checking with my data and revising double times, at least, to have the most important nomogram for that. I'm very conservative, like Dr. Khalid mentioned about advanced cases. I'm talking about kidney 60 or more. I'm very conservative. I usually don't do rings for kidneys above that, unless if the patient persists and resists to grafting. So I do it, and also patient expectation. I do explain to my patient thoroughly what will he expect. The complications that I present, especially vascularization extrusion, are common with thick segments which are implanted in advanced cases. The last point that I have to mention, I have to look also to the pupil size. We have the small optical zone and large optical zone. Patients with wide or large mesopic pupil select the segments with higher or wider optical zone to avoid distraction and visual phenomena. While I'm reviewing the literature, I found a very interesting topic regarding what's called neural processing or neural key factor. A study, I think, prepared by Professor Alio. He brought about 2,000 cases, put it in a computer system, and analyzed every aspect in the nomogram he mentioned and the outcome. And he said the validity of the outcome and the nomogram. Finally, he has his own nomogram based on this neural processing. And it's very, very successful, very successful. Thank you.
Yeah, last two cases I plan to do. Last two cases I had a plan to do rings for them. I gave the file to four physicians. I gave the file for you. I gave the file for you to choose the rings. I choose according to nomogram, and I asked Mr. Al-Alfi to send the file for somebody in UK, and I asked Dr. Salah to count his rings. Then I gathered the whole.
I see. Yes. So you don't need to be really rigid and religious in following the nomogram. You have to judge your experience. Either if you see a lot of myopia, two segments is better than one segment. And unfortunately, all nomograms went only in one direction, which is how thick. They looked at thickness and arc. So you see 150, 90, 120 arc. You see 200, 300, 400 microns elevations. But nobody really looked at, maybe it's the location of the cone which might make the difference. Maybe if it's the same ring, but we were able to channel it in the heart of the cone, and we reverse the cone attachment at that area, which bring back the cornea into a regularized situation. Maybe that's the reason. I mean, nobody looked at what location, how to find the cone location either by tomography or OCT or standard placido, which technique is better to find the site of the cone, and where should our ring be? Is it exclusion in the front of it, inclusion back of it, or dissecting it in the middle of the cone? This is really a very good topic really to study and might really change our approach to nomogram. Maybe not only just the arc and the thickness of the ring which make a difference, it's really what make a difference where we implant it. And what type of eye we implant it. Is it a central cone or a paracentral cone? And we agree that a paracentral cone give much better results, but taking this scientifically and addressing it might shed light in the future on the way we do our ICR. Yes.
Giving to be very liberal to do rings for many of the keratoconus patients. Instead, we definitely encourage to have very high selective criteria to have a successful cases. This is very important message. And the other message is we are tracking almost 400 cases since 2008, and we found almost 7 to 8% of them will present with extrusion and will end up with the grafting. So even by educating the patients at the beginning and patient counseling, you have to tell the patient this is not a permanent and perfect solution. In the future, you might have to do a grafting sometime in the future. We have a limited time to follow up our patients. I mean, maximum you have 10 or 15 years, but after that, we might have to give the patient an offer to do grafting. So, but giving the patient a window of improved, best corrected vision for that time, I think this is an achievement for these.
Any questions from the audience? Or yes, go ahead. Yes. Okay. You want to address this, Khalid? Huh? Do you induce presbyopia by implanting ICR in a 40 years old patient? And the beauty also is you can go back and remove one ring. See, if you put two rings and you say, I have a -8, -4 keratoconus, I put two segments, I will leave the patient on -2, he will not go into presbyopia, and you get really excessive correction from that ring, you can really remove one segment, or you can change the segment into a lower segment but this is, most of our patients are young, and in the cases we did not encounter a hyperopic shift to cause really presbyopia. Dr. Uthman?
I think the presbyopia may be related to the cross-linking in this age group, because it induces a lot of hyperopia after. So we don't want to do any cases above 36 with cross-linking. I think, in my experience, that is forbidden in those cases, because I have two cases which are really induced to up to 3 or 4 hyperopic after this age. So please, maybe this is without even if you remove the ring or even because there is a lot of pre-disseminate, the falls and precipitate, which increase.
And this is really in favor of doing sequential ICR, wait time, then do CXL. I agree with Dr. Uthman that I found that 3 bad prognostic factors for CXL, and at 4 o'clock you are invited for a CXL course. I'm sure we'll discuss this more depth. The 3 bad prognostic factors for CXL is smoking. Smoking, I will be surprised that if you cross-linked a heavy smoker, sometimes you get funny results. Large K reading, 58 or something. Sometimes they progress, and sometimes they give you a very refractive surprises. If you do a high K cornea, like 58, 60, and age. I think after 36, you have to be really careful when you decide to cross-link. Either you reduce the dose or really to question the need for CXL on those cases. But doing ICR in a 40, we did it. And I don't remember that any patient, those patients also have high coma. And we know that coma helps in delaying the presbyopic symptoms. Yes.
I found a great improvement in the near vision, not only for the near vision, but it aids to me a room of better reading glasses tolerance, because before, if you don't track, we are tracking the coma especially and the corneal aberration, so after the ring implantation, they are able now to wear the reading glasses they can read with. But before they are wearing the reading glasses, they cannot read.
One more question for the panel. Do you think there is a room for manual ICR? Can we say now in our country, ICR should be done femto? What do you feel, Khalid?
Advantage in favor of ICRs. It takes very less time and very predictable. Safety margins has increased dramatically. So I never do a manual at all now.
For those who don't have the femtosecond, please refer the cases to a center that have femtosecond.
Okay. Okay. طيب. Before we conclude, any questions? Otherwise, no questions? Otherwise, we really thank you for joining us. I hope we shared with you some information useful to you, and we are very happy to see you here. Thank you very much. Bye-bye.